Thank you, Dr. Ang, for your friendly words. Ladies and gentlemen, it's a pleasure for me to speak about a laser-induced procedure to treat presbyopia, and the title is Laser Blended Vision, a new option for the early presbyope. The history of corneal presbyopia correction, here is a summary about that, PRK and LASIK approaches. You see, they were started very early in 1991 from the German Till Anschütz and the Italian Paolo Vincingera and Dr. Nisola, and then from Luis Ruiz and from Telandro 2001. There are different approaches for presbyopia correction. Dr. Ang has just told it in the introduction. Multifocal IOL, accommodative IOL, scleral implants or scleral expansion, small diameter corneal inlay, like the camera lens, monovision, multifocal PRK and LASIK, increase in depth of focus, modified spherical aberration, femtosecond intracore procedure, and the laser blended vision, the aspheric PRK LASIK binocular procedure. There are approaches for near vision enhancement, bifocal or multifocal ablations with central near and peripheral distance from the Vizix company and the Carl Zeiss company from Bartoli, Italy. And there is the meiosis, the pupil contraction during accommodation to near distance, prolate corneal shape to have more refractive power in the pupil center, and the spherical aberration which occurs during the accommodation. And here you can see the spherical aberration during the accommodation in the time and in the change of the spherical aberration, the higher order aberration, and the sphere. But there are disadvantages of the bifocal cornea as well. You have two pictures at the retina, one for far, one for near. One picture is sharp, the other is blurry, or both are blurry, and you can have a lot of contrast, light scattering from transition zones. And though the solution is the increase in depth of focus, and it shifts the ocular spherical aberration into the plus range to improve the near vision. The blended vision is a combined approach for near vision enhancement, essentially combines the advantages of the monovision in increased depth of focus implemented through excess spherical aberration in both eyes, and is in fact a bilateral approach. Here you can see the management for a young patient, right and left eye, the presbyopic starting at 3 meter distance for a far distance, the presbyopia in the depth of focus starting in 0.6 meter, immediate monovision on the right eye 3 meter, on the other eye 0.6 meter, and now comes the combination, and this is a blended monovision. You can see there's a yellow zone, and this combines two eyes. We have done a study, a myopic study and a hyperopic study, and you see here the number of eyes in the preoperative myopic situation are 18 eyes. The pre-spherical equivalent was minus 3.4 plus minus 2.47 diopters, and after 6 months postoperatively for the dominant eye, it was minus 0.70 plus minus 0.38, and for the non-dominant eye, for reading, it was minus 0.90 plus minus 0.25 diopters. And this is a hyperopic population, mean spherical aberration preoperatively plus 1.68 plus minus 0.82 diopters, and the dominant eye after 6 months follow-up minus 0.01 diopters for the dominant eye and minus 0.95 diopters for the non-dominant eye. Here you see the age distribution in the hyperopic and myopic group, and it's starting in 35 years, but it's going on 45 years till 60 years. These are the main interested people to have such a laser operation. Stability, achieved correction spherical equivalent over the time. In the myopic group, you can see here is nearly no regression after 1 year, and in the hyperopic group you could see a very small regression up till 0.25 diopters after 1 year. Predictability, interesting to know what the patient expects, what the doctor could say. In the myopic group, it's a small undercorrection in the high Citroën -7 diopters, and after 12 months you can see as well after 6 till 7 diopters. That is about the limit in the myopic group. And in the hyperopic group there could come an undercorrection more than +4 diopters in the till 6 months and till 12 months as well. Safety, change in corrected distance visual acuity, you can see here. The green line are the myopic, the red line the hyperopic line, and they are gained more in the hyperopic group and in the myopic group, but we lost nearly no line. Monocular near visual acuity after 6 months, the cumulative uncorrected near distance acuity you can see here. Myopic group, JAGA 1 or better in about 90%, and in the hyperopic group, JAGA 1 or better in about 75%. JAGA 2 or better, both groups are 100%. And here the correlation between binocular near with binocular distance uncorrected visual acuity in the myopic group, you can see 20/20 visual acuity in 61% for the myopic and JAGA 1 or better, and in the hyperopic group it is a bit better, 74%. That subjective acceptance and satisfaction, there are good acceptance in both patient groups. The patients are nearly free from reading glasses and they have nearly no night vision problems. But there are complications as well. There are dry eye. There could be an endothelial dystrophy, a mild regression in a hyperopic patient group, and sometimes binocular difficulty instead of the binocular tolerance spectacles test. In summary, we can say that the blended vision combines the advantage of micro-monovision and increased depth of field in both eyes with a non-linear aspheric profile. There's a full correction of the dominant eye, intended undercorrection in the non-dominant eye. Laser blended vision increase with a non-linear aspheric ablation, the spherical aberration and prolate corneal shape. It provides an increased depth of focus for far and intermediate vision to the dominant eye, intermediate and near vision to the non-dominant eye. Thank you for your kind attention.